cerebrovascular accidents, stroke versus TIA. So first and foremost, cerebrovascular accident is the umbrella term for both strokes and TIAs. Okay, and this is characterized by a neurological deficit. The neurological deficit may be motor or sensory, and that's not necessary going to be in both the arm and the leg on that one side. It could be just one or the other. It could even be in the absence of any neurological deficit, and you could just have, say, for example, some sort of speech difficulty, such as expressive aphasia, receptive aphasia, conductive aphasia, those kind of things. So remember your Wernicke's areas, your Broca's areas, and that kind of area. So what is the difference between stroke and TIA? So like I said, CVA, cerebrovascular accident, is the umbrella term for both of these guys. And the difference is that a stroke is defined as being a neurological deficit that goes on for more than 24 hours, whereas that in a TIA, a transient ischemic attack, is a deficit that lasts less than 24 hours. Now, in terms of stroke itself, what you can have is generally two types of stroke. The first being ischemic, this is on the back of a thrombus, whereas the latter being hemorrhagic, which is on the back of an aneurysm that has burst. Don't forget, in the brain, you've got the berry aneurysm, which is on the circular Willis. And this, as a side note, is also associated quite heavily with PCKD, polycystic kidney disease. Now, just a little thing here, if I might very quickly go into ischemic stroke. Okay, so the ischemic stroke is such that the thrombus has actually occluded an artery in the brain. This is very similar to a heart attack, okay, in that an ischemic stroke, similar to a heart attack, in that your thrombus in the heart attack has occluded a coronary artery. Okay, so just a bit of a resemblance there to kind of take into account these concepts of VTEs, venothrombotic events. Okay, back to the stroke itself. So we use a criteria, and that is the ROSIA criteria, the recognition of stroke in the emergency room. Okay, and this is important because what we want to do is want to recognize and intervene within this timescale of 4.5 hours. And this is guidelines. These are very strict guidelines, both NICE and from the Royal College of Emergency Medicine. If we can appreciate, recognize, diagnose an ischemic stroke from the onset, 4.5 hours from the onset of symptoms, and actually intervene and perform thrombolysis, we will get extremely good outcomes for the patient with very minimal long-term damage, which may be life debilitating. So where do we go then? How do we go about making the diagnosis and doing what we need to? Well, we go for the CT head. That's the absolute first thing that we do. Now, this in contrast to an MI, if we are suspecting an MI, the first thing we do is actually we give a 300 milligram aspirin stat. Whereas, amongst other things, of course, but here in the CT head, we do not do this. Okay, we do not do that 300 milligram stat aspirin. What we do first is a CT head, and the reason for that is because we want to determine whether this is ischemic or hemorrhagic. If it's hemorrhagic and you're giving that 300 milligram aspirin stat, then what's going to happen is you're going to further exacerbate the actual issue. You're going to further prevent the patient, well, basically, you're going to cause the patient to bleed and potentially to death. So that's the important, very, very, very important consideration to appreciate. Once you've done the CT head, what are you looking for? So the most common site, or one of the most common sites of the thrombus is the middle cerebral artery. Remember that runs in the sylvian fissure, and what you will see on the CT head is you will see what we call GAX sign. So you'll see a hyperdensity in that middle cerebral artery in the sylvian fissure. So now that we have confirmed that this is an ischemic stroke, what we're going to do, yes, we're going to give the 300 milligram aspirin stat, and what we're going to do is consider giving the patient lifelong clopidogrel, amongst a whole host of other things in terms of the workup for the patient. In terms of hemorrhagic stroke, so if you said, okay, the CT demonstrates a hemorrhagic stroke and you don't see this GAC sign and everything else, and instead you see evidence of an acute bleed, an intracranial bleed, And remember here, we could be looking at a subdural hematoma, we could be looking at subarachnoid hemorrhage, and so on and so forth. If it's hemorrhagic, then what we need to do is we need to do a referral to neurosurge. So we will hemodynamically stabilize the patient. In all cases of stroke, we're going to do the A to E examination, of course. And what we're going to do here is we're going to ensure that the patient is hemodynamically stable. And again, amongst a whole host of other things, the main thing here to do is neurosurgery. And that's essentially your stroke. Now, if what we've got is, if we've got a TIA, then what we're going to do is this management here. And this you don't really need to know at this stage, but in situations where we're suspecting a TIA, again, we'll give them the 300 milligram aspirin stat there and then. We'll do a TIA referral, refer to the TIA clinic. We'll then give them a 300 milligram aspirin once daily, and they will do that, and it will take one of those until the TIA clinic have actually reviewed the patient, and they will then inform the management. So this is a medication to be taken away from the emergency room. I hope that helps. Thank you for watching.